Hello, guys. My name is Dr. Sayed Kazmi. I'm a pediatrician with special interest in pediatric pulmonology. And today I'm going to talk about the pediatric COVID-19 infections. Um, I've been repeatedly asked by my colleagues as well as my students to give them some information regarding this current pandemic because there is a bit of paucity of literature regarding the pediatric infections by coronavirus disease 19. So I'm taking this opportunity to give you some facts for the pediatric practice. So I'll start with the background. You all know that this coronavirus disease started in one city of China, Wuhan, in late December in 2019, and from there it has gradually spread to the rest of the world to the extent that it was then declared as a worldwide pandemic by the World Health Organization. The pathogen identified for this disease is known as SARS coronavirus 2, and the disease has been called coronavirus disease 19 by the WHO. So far, globally, the statistics shows that more than 200,000 have been affected, majority of them being adults and elderly. The current statistic says that the rate of pediatric infections have been less than 2%. Now, as far as the global impact of this disease is concerned, it has severely hampered economic activities all around the world. There is a rough estimate that the economic costs are considered to be in trillions of dollars. Worldwide, the airline industry has gone down. The tourism industry has been has been shuttered, and similarly, other economic activities have almost come to a halt. Stock markets around the world have crashed, and we don't know how long it's gonna last and what will be the long-lasting economic impacts of this pandemic. Okay, the pathogen is known as the coronavirus. The coronavirus is basically considered to be an animal virus because it mostly causes infections in animals like bats, civets, pangolins, camels, snakes, ducks. But the Center for Disease Control in the United States has identified 7 strains of the coronavirus that can cause human disease. They are classified into alpha, beta, and gamma coronaviruses. Some of them are quite common in causing common cold in humans, and they are the alpha coronavirus 229E, alpha coronavirus NL63, beta coronavirus OC43, and beta coronavirus HKU1. So these 4 viruses, they cause common cold in humans. 3 strains of the coronavirus are quite deadly because they cause quite severe disease, viral pneumonias in human beings, and they are known as the MERS coronavirus, which stands for Middle Eastern Respiratory Syndrome coronavirus, the SARS, that stands for the Severe Acute Respiratory Syndrome coronavirus 1, and SARS coronavirus 2. Now, the Middle Eastern Respiratory Syndrome coronavirus is known for the Middle Eastern outbreak of coronavirus, and that was in 2011 and 2012 in the Middle Eastern countries, and that was caused by a mutation of the camel strains of coronavirus that eventually jumped onto the humans and then caused a transmission from humans to humans. The mortality of that virus was considered to be around 10%, rather the case fatality rate was 10%. So of all those cases that happened in the Middle East, 10% of them died. Then the SARS coronavirus 1, this was famous for causing the China epidemic back in 2002, and it also caused a worldwide scare. Now recently, SARS coronavirus 2, which is basically the same coronavirus but has mutated from that one and has got a slightly different genomic imprint. Now this is the one which is responsible for the current outbreak, which is known as the COVID-19 by the World Health Organization. And as I said earlier, more than 200,000 people currently all over the world have been affected by this virus. Now, if you look at the shape of this virus, so you will see that it has got spikes on on its surface over here. Can you see these spikes? So the corona is name is given because of this peculiar uh, shape of the virus. And here that you see these things, they are known as the S glycoprotein. And S glycoprotein is that glycoprotein which actually has got affinity for the angiotensin converting enzyme 2 on the type 2 pneumocytes in human alveoli, and which makes it quite easy for for the virus to attach to the receptors and then go inside, replicate, and then cause the disease. Moving on, we will talk about the pathophysiology of the coronavirus. Now, if you look at this diagram, so this is the human lungs, this is the trachea and the two main bronchi, and they then branch down finally into terminal bronchioles and then the alveoli. Now, the alveoli over here are lined by two different types of cells. They are known as type 1 and type 2 pneumocytes. They have got special roles, both these types of cells. So type 1 is responsible for gaseous exchange. So when we inhale, we take in oxygen. So the oxygen diffuses into the blood and the carbon dioxide diffuses out through the type 1 cells. The type 2 pneumocytes are specialized cells, and you can see over here, these cells are responsible for producing surfactant, and surfactant is responsible for maintaining the surface tension of the alveoli that keeps it open. Now here, if you look at the shape of this cell has got different types of receptors on the cell membrane, and one of these receptors is known as ACE2 receptor. Now this ACE stands for angiotensin converting enzyme 2 receptor. You all know through your knowledge of physiology that the angiotensin 1 is converted into angiotensin 2 by the angiotensin converting enzyme, and then the angiotensin 2 acts on its receptors, and then what happens in turn, it activates the renin and aldosterone system in the kidney that helps in maintaining the blood pressure. Now, as I said earlier, that there are spikes on the surface of the coronavirus, which has got the S glycoprotein. So this S glycoprotein has got a very high affinity for ACE2 receptors. So when somebody coughs, or let's say somebody somehow gets an infection, like either through the droplets, either through the fomites, or somebody is coughing and the affected person then inhales. So what happens when they inhale, the virus particles, they go inside and somehow they reach the end of the alveoli. There the viruses, the coronavirus, they attach with the ACE2 receptors because of the high affinity, as said earlier. And what then happens is a process of endocytosis, in which the whole virus along with its receptor is taken inside. So it is engulfed and then is taken up in a lysosome. So here you can see that this is a lysosome which is covering the virus particle. Now, there is a special enzyme which helps in degradation of the lysosome. So that enzyme actually is activated, and when that is activated, what happens is that this would burst open, the lysosome would burst open, and the virus would be released along with its RNA. You all know that the coronavirus is a single-stranded RNA virus, and it releases its RNA. So here you can see the single-strand RNA. Now this single-strand RNA is then taken up by the ribosomes of the type pneumocytes. So what happens? These ribosomes, they take up the messenger RNA, and this messenger RNA then, with the help of an enzyme which is known as polymerase dependent RNA polymerase. So what does this enzyme do is that it simply causes this RNA to make further copies of the RNA. So it helps in making many copies of the RNA. And then at the same time, this messenger RNA gives message to the ribosome to make different types of proteins. These proteins, which are large proteins, are then acted upon by different types of proteases, which break down these proteins into the other types of proteins like the nuclear capsid, the envelope proteins, and other things. So all the raw material for the for the virus is being made. And finally, all these different types of proteins are combined with the different copies of the RNA, and different sets of new viruses are formed, which are then ultimately released by the cell. The cell bursts open, and then they go on infecting other cells, and the process repeats itself again and again. What happened at the same time is, as that this viral replication is going on, it leads to, when these cells are burst open, what happened is that there is release of cytokines in the blood, and these cytokines are many. Some of them are interleukin 1, interleukin 2, and tumor necrosis factor alpha. Now what they do is, these are inflammatory cytokines, so they increase the vascular permeability, they activate the complement cascade, and what happens is that you will see that the vascular permeability is increased, and there is fluid accumulation in the interstitial spaces between the alveolar cells and the blood vessels. So this is known as interstitial edema. At the same time, as these type 2 cells are damaged, what happens is that we get a lot of exudates containing virus particles in the alveoli. So the alveoli are getting filled with fluid. So as they are getting fluid with filled, what happens is the oxygen, that is the air that is coming in here, what happened, the gaseous exchange of taking in of carbon dioxide and giving out of taking in of oxygen and giving out of carbon dioxide cannot happen at the alveolar level. So there would be impaired gaseous exchange. So this fluid, which is known as the interstitial edema, as well the alveolar edema, what happened, that would make the lungs quite stiff. And when you do an x-ray of these types of lungs, you would see a ground glass appearance, which is quite typical of the what we call as acute respiratory distress syndrome, and which is again a hallmark of the coronavirus pneumonia. At the same time, most of the time it is a localized inflammation, just confined to the lungs. But sometimes what can happen, these interleukin 1, interleukin 2, interleukin 6, and tumor necrosis factor, all of them, they can also incite an inflammatory cascade away from the lungs. That is, it can cause inflammation in a heart, it can cause inflammation in the kidneys, it can cause inflammatory cascades in the liver, and this is what we call as the systemic inflammatory response syndrome, and that would lead to a cascade which will ultimately end up in what we call a septic shock. So the person would be tachycardic, they would be having low BP, and they would eventually go in multi-organ failure, which is the number one cause of death in these persons. So that's why it can be quite dangerous if there is an overwhelming replication of the virus, and at the same time the inflammatory response gets out of order. It becomes a sort of a dysregulated and causes a wide activation of these inflammatory cascade in organs like heart, kidney, liver, etc., which can ultimately end up in septic shock, and that can ultimately lead to death. Now the thing is that children basically they have got paucity of ACE2 ACE2 receptors in their lungs. So what does it mean? That they do not have enough ACE2 receptors in their lungs. That's one of the reasons that this virus does not affect children to that extent that it affects the adults and the elderly. So one reason is that there are not enough ACE2 receptors, so it's not easy for the virus to replicate and then cause a sort of a severe infection. Number two, children have got a very strong immune system, and at the same time, they repeatedly get infections from other strains of coronavirus, as I told you earlier, the alpha and the beta coronaviruses, which cause common cold. So there is some extent of immunogenic challenge that leads to some form of cross immunity. So children do have some form of immunoglobulins which are there, which have got some predisposition to attack these viruses. So that's why even if the kids they get this virus inside, the immune system is able to suppress it in early stages. So majority of them, they would get a mild illness or maybe even asymptomatic. And that's one of the reasons that the current in the current pandemic we have seen that the global share of the population, pediatric population that has been affected is less than 2%. And even among those who have been affected, the overall mortality in pediatric population is very low. And in China, the doctors and the scientists, they have done some research. There have been recently some papers that have been published in New England Journal of Medicine, and they looked at those kids those who died, and they found out that all those kids that died of the severe coronavirus, they had underlying problems like hyperplastic kidneys. One of them had underlying intussusception and also had other comorbidities. So most of the time, children would either be very mildly affected, or even if they are affected, they would have very mild symptoms, which would be, usually pass under the radar. Most of the doctors, they won't think that this is caused by coronavirus. And as I said earlier, that those who come up with severe disease, coronavirus disease, are usually those who have some underlying health problems, respiratory problems, or any other types of problems. So this is quite characteristic of the pediatric COVID-19, and that's why we have seen a less burden of disease in the pediatric population. This is data from a recent article that was published in the New England Journal of Medicine on the 18th of March 2020, and it looks at the characteristics of pediatric COVID-19. This was research done by Zhang et al., and they have looked at the characteristics of 171 children who were diagnosed with SARS coronavirus 2 in China. And it's quite interesting, as if you see, majority of the children who were affected were between 1 to 10 years of age. So if you see, though it has been like evenly distributed between different age groups, but if you see here, 23.4% were between 1 to 5 years, and then 33.9 were between 6 to 10 years. Very few of the kids less than 1 years were affected, just 18%. And again, as I said, that the younger population have got paucity of ACE2 receptors, so that may be one of the cause that less number of younger children were affected. Predominantly, for some reasons, males were more affected as compared to the females. And again, if you see those who were tested positive, of them 15.8% here, they were completely asymptomatic. So they were tested positive, but they were not exhibiting any signs and symptoms. So they were absolutely fine as far as their clinical characteristics were concerned. 19.3% of them, they presented with upper respiratory tract infection. So they had like mild cough and cold like symptoms, which you normally know can be caused by more than 200 different types of viruses. And normally we do not test these kids for different type of viruses because it doesn't change the management. It's all supportive. But nevertheless, 19.3% of these kids with like URI symptoms were suffering from COVID-19. and 64.9%, so this is around about two-thirds of those affected had some form of pneumonia. So either it was radiological pneumonia or it was clinical pneumonia. Clinical pneumonia is based on like fast breathing, maybe some form of chest and drawing, and focal signs, on auscultation like crackles, or it could be radiological pneumonia where you find like uh, rounded or triangular opacities in one or both of the lung fields. Uh, they also found out that majority of those kids that were diagnosed with COVID-19 infection, they also had a positive family cluster. It means somebody in their family was already diagnosed with COVID. So that simply means that it usually affects the close contacts, and only 8.8% were those who had no clear-cut source of infection. So we don't know how they picked up. Might be droplet, fomites, you never know. And very few, 1.2%, had a contact with another suspected where we thought that they might be harboring because they had mild symptoms, but we had like though they didn't had any data about those. As far as the signs and symptoms are concerned, again, we see 50%, round about 48.5% presented. The predominant feature was cough. 46% had some pharyngeal congestion, and 41.5% had fever. And the median duration of the fever ranged somewhere between 1 to 16 days, while the median, like 50% of those kids that were affected, had a fever range of 3 days. So the thing is that fever with cough and pharyngeal erythema, which is again very very non-specific because it's not very sensitive and not very specific clinical signs for COVID-19. I mean, you can get it in upper respiratory tract infections, again as I said, which can cause by different types of viruses. You can also get it in tonsillitis. You can also get it in viral vectors, etc., etc. Now, the highest, again, interesting thing is that those who are hospitalized, 58.5% of those had a fever less than 37.5. So they were not febrile in hospital. 9.4% had a fever ranging between 37.5 to 38, and 22.8% had a fever which is considered to be moderate fever, 38.1 to 39, and only 9.4% had a high fever more than 39%. So in children, you see majority of them have got very mild or almost no fever. And then some features were sort of less common, like diarrhea, fatigue, rhinorrhea, vomiting, which were like cumulatively in less than 10% of the cases. Abnormalities that were detected on the CT of the chest that was done was 32.7% of them had ground glass opacities, which mean that there's some form of acute respiratory distress syndrome. 18.5% had local patchy shadowing, means some form of pneumonia. Bilateral patchy shadowing in 12.3%, and some interstitial abnormalities, which are again very non-specific, in 1.2% of the cases. So again, if you look at this data, the crux is that there is no single feature which helps in classifying these pediatric population who present with cough and fever as to be specific for COVID-19. So most of the times, these signs and symptoms are present in common cold, in viral V's, in pneumonia. So it's very difficult to classify on the basis of clinical signs and symptoms. So the only thing left for diagnosis is doing a viral PCR for COVID-19. But again, the question is whether it should be done in mild cases and whether it makes any difference to the treatment offered, because these are expensive tests, and so many factors have to be considered while offering these tests. Here in the UK, the Public Health England has issued guidelines, and only those people are tested for COVID-19 which have got particular criteria. So they have published a clinical criteria and epidemiological criteria. If somebody who is fulfilling that criteria, and they have to be, like, their condition is such that they have to be admitted, so only then they would do their viral PCRs. If they are just suspects, they are asked to self isolate themselves at home. And in case if there is any deterioration, then they can be brought to hospital. So there are pathways for that. But like if they are fine, they are just self isolating. And if they are unwell, then they have to be hospitalized. And again, there are protocols for that. Now, the diagnosis, as I said earlier, that current guidelines recommend tests only for those cases who fulfill a clinical and epidemiological criteria. As I said, the sign and symptoms can be because of different things. So it is not economically possible that anybody who comes with a cough and cold, okay, they would be offered testing, because then it would be then it would have, like, huge economic cost, and would not be sustainable. So if somebody who has traveled or come in close contact with a suspect or with a positive case, or who are high suspects, or who are not doing well and they've got radiological evidence of pneumonia, or they're coughing or new onset cough, things like that, they are offered this testing. And these days the real time PCR takes 5-6 hours, and you can get the results, and then accordingly treatment can be offered. Now there are two types of swabs that are taken from the throat and from the nasal cavity. So one actually is tested for COVID-19, that is the real-time PCR, and the other one actually tests for different types of other viruses, which is called the respiratory viral panel. At the same time, to supplement the diagnosis, radiological diagnosis is also used, and basically it is used to aid the severity of the disease, because they have to be classified if they are suffering from severe lung disease, and whether they need to come in. And for that we use chest x-rays and CT of the chest. Now, CT of the chest is not routinely used in pediatric population because of the radiation involved. So chest X-rays are used, and if there is any consolidation, suspected opacities or ground glass appearance, uh, coupled with clinical symptomatology and low SATs, then they have to come in. They have to be admitted, and supportive treatment is given to them. Royal College of Pediatrics and Child Health has issued guidelines for management, and this management is basically, as I said earlier, the majority of them, they present with mild illness. The mild illness cases have to be isolated at home. Now the thing is that kids are very closely related with their parents. Okay, so we take kid with their parent as one unit. So the guidelines currently say that if the child is well and the parent is also well, then the child and the parent, they go home and they isolate themselves for 14 days. So the current recommendations say they have to isolate themselves at home for 14 days. Well, if the child is well, but the parent is COVID-19 positive as well, and he's like having some form of level 1 care. Level 1 care means that the parent has got a disease that he needs to come in, he needs to be hospitalized. Then the parent stays in the adult ward, while the child goes for home isolation here in UK, and they get support from the social care. So the social care, social workers, or the foster parents or foster carers, they would come in and they would look after the child. If the child is well, but the parent is needing a high dependency care, he's in the ITU or in the intensive care, then again the child goes to home for home isolation and support from social care, while the parents, they stay in the ward, and again they would be treated as per the local ITU or ICU policies. If the child is hospitalized, the parent is well, then the child needs to be in the pediatric cubicle in the ward, and the parent would stay with the child. So the parent has to stay with the child in the hospital, despite the fact that the parent is well and the child is COVID-19 positive. If both are admitted, then the child would be in the pediatric cubicle and the parent would be in the adult ward. And again, it depends on the local guidelines. Sometimes they would try them to bring them together if that is possible, otherwise not, and so on and so forth. You can just give a read to these the rest of the guidelines, that what has to be done with the kid and with the parent if both of them are affected, and the severity of illness varies depending on whether they are hospitalized in level 1. Level 1 here in UK means a general ward, so a pediatric ward or an adult ward. Level 2 means a high dependency unit, either in the pediatric ward or in the adult ward. And level three means intensive care, so it would be a pediatric intensive care unit or an adult intensive care unit. Coming down to the treatment. Now, at the moment, all that is being offered is supportive treatment. Now, for kids, majority of them are asymptomatic or have got mild illness. So the thing is that they do not need any treatment. All they need is just like if they've got fever, paracetamol 4 hourly, okay. They have to be kept well hydrated, okay. They have to be kept in home isolation for 14 days. The only thing that is a bit challenging is that kids, they do not like masks, so it is very difficult to keep mask on the kid. So again, it's a bone of contention as to how much the kids can spread the infections to the other household contacts. But nevertheless, at the moment, the current guidelines says that they have to be with their family members and they have to be isolated at home for 14 days. So I said earlier, mild cases don't need any treatment. All they need is supportive treatment in the form of paracetamol and hydration. And if there is any sort of focal signs like wheeze or something, you can treat it with bronchodilators. Moderate cases, they need supportive treatment in a care setting. So these children would either be having a low SpO2, low oxygen saturation, less than 92%. They would be having tachypnea. They would be having increased work of breathing, though they're quite rare, but they need to come in, and they would be either admitted in the ward, or they, if the disease flares up, then they need to go to a high dependency unit. And again, as I said, very few, less than 0.6% of the total pediatric affected cases would need level 3 care. That means PICU, and in PICU mean that they need to be on the ventilators. So ventilator support, again, there are different settings which are used for ARDS, low tidal volumes, high PEEP to recruit the alveoli, and they have to be on ventilator till the edema settles down and the lungs can function again effectively. If the ventilators are not giving any help, then ECMO is another mode of oxygenation which can be used, that is mostly used in the tertiary care hospitals. So these are the current supportive treatment modalities that are offered to pediatric cases. And as I said, like this is the same for adults, this is the same for pediatrics at the moment. But as I said, luckily very few part of the pediatric population is affected. There are a few experimental drugs which are currently being trialed. One of them is remdesivir. So remdesivir is an antiviral, and you might know this was a drug that was used in the for treatment of Ebola back when the Ebola outbreak occurred in 2015. So what this drug does is that this blocks the enzyme, okay, which is responsible for elongation of the viral RNA. So once this is blocked, then the viral RNA cannot replicate, and if it cannot replicate, then the viral particle will not be having enough RNA, and the virus cannot make its copies. The other drug is chloroquine, or it's called another sort of an isomer known as hydroxychloroquine. Now, this is basically an anti-malarial drug, and is quite used in the tropics as well as the temperate regions where malaria is quite common. This drug basically is anti-protozoan, but at the same time, recently the trials have shown that earlier we were discussing that in type 2 pneumocyte, when the virus is engulfed inside, what happens is that it is engulfed in a lysosome. Now this lysosome is then degraded. As it degraded, what happens is that the lysosome bursts open and the virus particle comes out and releases its RNA for replication. Now, this hydroxychloroquine blocks that enzyme which is responsible for degradation of the lysosome. So once this enzyme is blocked, the virus particle which is taken inside the lysosome, it will stay inside and it will not be able to come out of the lysosome. So this hydroxychloroquine actually blocks this, and that's how it exerts its effects. And they say that if that is combined with azithromycin, azithromycin, is a macrolide, and it has also got antiviral properties. So they say this antimalarial hydroxychloroquine with azithromycin has shown to have very good um, effects in blocking the replication of this virus. And then the third drug is ritonavir. Ritonavir is basically an protease inhibitor. So protease inhibitor, as I said earlier, that once if the RNA, messenger RNA, is replicated and then it enters the ribosome and orders it to make copies of different proteins. These proteins are broken down into different types of viral particles like the surface protein, the nuclear capsid. So there are different types of proteases which actually break down these larger proteins into virus proteins. So if this enzyme proteases are blocked by the ritonavir, which is a protease inhibitor, so what would happen? These viral big particles would not be able to make small specific proteins for the virus. So what would happen? The virus would not be able to replicate and would not be able to make its own copies. So that's how remdesivir, chloroquine, hydroxychloroquine, azithromycin, and ritonavir, they can help in stopping the replication of COVID-19 virus. There have been a few vaccines which are under development. Germany is working on developing a vaccine. In United States, they have also prepared a vaccine. They have started some trials as well. We don't know how much effective they are. Only time would tell us whether they are any effective or not. But for the time being, as the pandemic is propagating, uh, lab experiments have shown that the virus is destroyed when the temperature goes beyond 40 degrees Celsius. So around somewhere 43, 44 degree, this virus cannot replicate, it dies. So hopefully, as the summers kick in, probably as the temperatures would rise, so most probably the burden of infection and virus replication would go down, because the virus would not be able to survive in hot weather. So we are hoping for the best, and let's see how this whole pandemic unfolds in the coming months. But fingers crossed. At the moment, we have got only a supportive treatment. And in a nutshell, as I said earlier, that luckily pediatric population is not that much effective. The signs and symptoms are very non-specific. We don't know whether these signs and symptoms are being caused by a simple common cold or whether they are being caused by COVID-19 infection. The treatment in any case is just most of the time is just supportive. Very few unlucky of them with underlying problems would ultimately end up in hospital in high dependency unit or in pediatric intensive care unit. If you've got any questions, queries or comments and would like to ask me, just throw me a comment or contact me, and I would try my level best to answer your questions.